Good morning, all. I am presenting this patient on behalf of the Medicine 2 unit. This is 47-year gentleman from Meghalaya, a teacher by profession, presented to us with complaints of pain over the right side of the face since 1.5 months, which was constant pricking in nature without any radiation, associated with right ear pain with no discharge, no tinnitus or hearing loss. There was history of right-sided numbness over the face since 1 month, deviation of mouth to the right side and with slurring of the speech since 1 month. He noted weight loss of 12 kgs over the past 1 month with a dry cough 1 month, the progressive dysphagia to more for the solids, and noticed the nasal twang to his voice. He was a chronic smoker who reformed 2 months ago. Prior to this, he smoked 12 cigarettes per day for more than 20 years. On examination, his vitals were stable with a BP of 120/80, pulse rate of 88, respiratory rate of 22. And general examination is insignificant. On examination of his central nervous system, his higher mental functions were normal, except for his minimal slurring of the speech. And his examination of the cranial nerves revealed decreased sensation at the cheeks, decreased clenching of the mouth, and a sluggish corneal reflex, reduced wrinkling of forehead over the right side, reduced tight closure of eyelid over the right side, and reduced blowing of the cheeks over the right side, and a flattening of the nasolabial fold in the right side. The sluggish gag reflex. The tip of the tongue is noted to deviate to the right side. His motor system and sensory system, cerebral systems were unremarkable. His gait was normal. Other system findings were unremarkable. So with the syndrome complex of dysphagia, right-sided face pain and numbness with deviation of angle of the mouth, change in voice, slurred speech and sluggish corneal reflex, right side deviation of the tongue, multiple progressive LMN cranial nerve palsy was identified. I would like to go for the clinical localization in this patient. It's clinical localization.
Any answers from the audience? Any answers? Skull base. So there's some localizations to the base of skull.
Thank you. So approaching him through this algorithm from the textbook of Bradley, establishing anatomical localization and the possible etiology. Regarding anatomical localization, to differentiate either to intrinsic or extrinsic brainstem, we noted there was no long track signs and also no crossover of the signs noted. So we excluded the extrinsic and looking into the excluded the intrinsic and looking over the extrinsic areas where these lower cranial nerves were grouped. We thought of the following areas: jugular, foramen, posterior lateral condylar space, retropharyngeal space, retroparietal space. But these included only the lower cranial nerves. Considering the involvement of the 7th and 5th nerve, we came to a conclusion of the skull base involvement in this patient clinically. This was described in this De Jong's book of clinical neurology. The skull base involvement of variable progressive cranial nerves as Gaussian syndrome. So moving to the etiological diagnosis, we had these differentials of a neoplasm or a vascular etiology as aneurysm, some infections, immunological reactions, and degenerative changes. We investigated him, which revealed normal counts, ruling out infections, and his inflammatory markers were low, ruling out inflammations. We did a CSF analysis that ruled out further CNS infections. And we did a radiological imaging, MRI CT base of skull, that showed the enhancing soft tissue in the right parapharyngeal space and the right carotid space, that involving these areas, right infratemporal fossa, eustachian tube, lateral wall of the nasopharynx with intracranial extension through foramen ovale. And further biopsy, it showed poorly differentiated squamous cell carcinoma with focal sarcomatoid differentiation. This is a representational image. So nasopharyngeal carcinoma is found in him, which was a multifactorial carcinoma. Smoking being an important risk factor. 3 types of histologies were identified: keratinizing, non-keratinizing, and squamous, among which undifferentiated non-keratinizing is present in this patient that has a poor prognosis. By staging, he is in T2 M0 N0 stage of 2. So after having a discussion with the medical oncology team, head and neck surgery team, and radiotherapy team, we proposed him the treatment of docetaxel and capecitabine and cisplatin for 4 weeks for induction. Further course of the treatment to be planned after the 4 weeks. He is having this treatment, started his treatment on his hometown, and he's on regular telephonic follow-up, and he's tolerating drugs. So regarding this Gaussian syndrome, there was only one case report till now in India, nasopharyngeal carcinoma initially presenting with multiple cranial nerve involvement. So from him, I learned to have a schematic approach in case of multiple cranial palsy, establishing an anatomical diagnosis prior to the etiological diagnosis. Thank you.
Thanks, Dr. Sivaranjani, for this quick and nice presentation. Any questions? Yeah, this is also a good neuro case for final year MD students. Please examine. Yeah, thank you so much. So actually, it means you found him in the late stage, because nasopharyngeal carcinoma is asymptomatic for quite some time before it involves a base of skull. Thank you.
Thank you.